Welcome to the deep dive. Today, we're strapping in for a really fascinating look at hyperbaric oxygen therapy, HBO, and its potential for neurological disorders.
Yeah, it's a big topic.
It really is. We've got a scientific book chapter here as our guide, and it's pretty dense,
Huh.
digging into how HBO actually interacts with the brain, both healthy brains and brains facing serious issues.
Right, it covers a lot of ground.
So think of this as our attempt to really get under the hood, understand how breathing pure oxygen under pressure might affect things, and what the actual science says about using it as a treatment.
Exactly. Our mission, if you like, is to translate this complex science and see what the evidence really suggests. The chapter we're looking at gives a great overview, from basic brain metabolism right up to, how they actually measure if it's working.
It seems like a solid starting point to understand the why behind it, not just the if.
Precisely, it helps connect the dots.
Okay, so let's jump right in. Where do we start? How does HBO actually, affect the brain's energy system? That feels fundamental.
It really is ground zero. The basic idea is, look, many neurological problems involve the brain not getting enough oxygen, that's hypoxia or ischemia. HBO is designed to flood the system with oxygen to combat that.
Makes sense.
Now, you might remember the Pasteur effect from biology?
Vaguely. Refresh my memory.
Okay, so basically, when cells have plenty of oxygen, they prefer using it for energy production. It's more efficient. In the brain, especially with cerebrovascular issues, when you introduce the high oxygen of HBO, you see this effect. There's an inhibition of glycolysis that's breaking down glucose without oxygen.
So less sugar burning when there's lots of oxygen.
Kind of. You see a decrease in lactate and pyruvate production, and overall glycolysis slows down. This seems linked to slightly reduced blood flow, which we'll get to, and that small bump in brain oxygen levels.
Okay. But the chapter also mentioned a reverse Pasteur effect. What happens when oxygen is low?
Right, so that's the flip side. When the brain's starved of oxygen, its energy levels ATP drop. That drop triggers this reverse effect. The brain basically panics and ramps up glycolysis, trying to squeeze out any energy it can from glucose,
Right.
even though it's inefficient without oxygen.
Wow, okay. Like a desperate backup generator kicking in. Now, what about this GOQ thing, the glucose oxidation quotient? What's that telling us?
The GOQ, think of it as a marker for how effectively the brain is using oxygen to burn its main fuel, glucose. Normally, it's at a certain level, reflecting that efficient oxygen-based process.
When things go wrong, like not enough oxygen.
Well, in anaerobic conditions, that GOQ score goes up. It shows the brain is relying more on that less efficient, non-oxygen pathway to use glucose.
Got it. So this Holbach study from the 70s seems pretty key here. What did they find when they used HBO on injured brains?
Hugely important study. Holbach's team found that using HBO at 1.5 atmospheres, absolute 1.5 ATA, seemed to help normalize that GOQ in injured brains. It suggested improved oxygen utilization.
That sounds positive.
It was, but here's the kicker. When they increased the pressure to 2 ATA, things actually got worse. The GOQ increased, the brain took up more glucose, but didn't use oxygen better. It's a crucial point. More pressure isn't always better. 1.5 ATA looked like the sweet spot there.
Really important distinction. Okay, and then there was that rat study, Contreras, with the brain lesions, that showed effects lasting after the HBO stopped.
Exactly. They gave rats HBO at 2 ATA for several days. Even after the treatment finished, the rats' brains continued to show increased glucose utilization.
So it's not just a temporary boost while they're in the chamber.
It suggests not. It implies HBO might trigger some longer-lasting adaptive changes in brain metabolism. That could be why some patients report sustained clinical improvements.
And this finding about severe traumatic brain injury, TBI, where the benefits sometimes only appear after treatment, that seems a bit odd.
It does feel counterintuitive, yeah. The current thinking is that HBO might act like a primer. It makes the brain tissue better equipped to use the normal oxygen levels it receives after the hyperbaric sessions end. Like, it helps the engine run more efficiently on standard fuel later on.
Interesting. And that Roxwold clinical trial combining HBO with NBH normobaric hyperoxia.
Yeah, that looked promising too.
Yeah.
They compared HBO alone, NBH alone, and the combination. The combo group showed better markers for oxidative metabolism, less intracranial pressure, a huge deal in TBI, fewer signs of brain toxicity, and ultimately lower mortality and better outcomes.
So a potential synergistic effect.
It certainly points that way. Using them together seemed better than either one on its own in that trial.
Okay, one last metabolism point, this cyanide poisoning example. HBO plus hydroxycobalamin.
Yeah, pretty specific but illustrative. Cyanide messes up oxygen use by cells. HBO helps by slowing the cyanide buildup in the blood, while the hydroxycobalamin acts like a scavenger. The animal study showed this combo had lasting benefits on brain metabolism after poisoning.
Okay, fascinating stuff on metabolism. Let's switch to cerebral blood flow, CBF. The general rule is oxygen constricts blood vessels, so HBO usually reduces blood flow.
That's the general principle, yes. High oxygen levels seem to interfere with nitric oxide, or NO, which is key for relaxing blood vessels. There's an enzyme, SOD3, involved in regulating this NO availability. Hyperoxia seems to counteract NO, leading to vasoconstriction.
But the chapter mentions some studies found increased blood flow. How does that work?
Right, it's not always straightforward. One idea is the inverse Steele or Robin Hood effect. If HBO constricts vessels in healthy areas, it might actually shunt more blood towards damaged areas where vessels have lost their ability to react.
Diverting resources to where they're needed most.
Sort of. Another possibility is that by reducing overall swelling and intracranial pressure through vasoconstriction, HBO might improve the pressure gradient driving blood flow into certain compromised areas.
So the state of the brain tissue itself is crucial.
Absolutely. In a normal brain, you generally see reduced CBF. But in a brain with edema or high pressure, HBO might actually improve flow by tackling those issues. This study looking at microcirculation after ischemia highlighted how swelling can worsen oxygen deprivation, and HBO seemed to help with that edema.
And that old idea about a two-stage effect, constriction then dilation.
Yeah, Bean suggested that back in '71, an initial vasoconstriction, possibly followed by vasodilation if the exposure is prolonged, maybe as the control mechanisms get fatigued or overwhelmed. It suggests a dynamic response.
Okay, so overall, usually vasoconstriction reduces CBF, but it depends on pressure, time, brain region, existing damage. It's complex.
Very much so. And some even propose that reduced CBF might be protective against oxygen toxicity, limiting the delivery of potentially harmful high oxygen levels.
What about that rat study at a really high pressure, 5 ATA? That sounded concerning.
It did raise concerns. They found reduced CBF in injured areas at that high pressure, and they speculated this reduction, maybe combined with neurotransmitter imbalances, could contribute to seizures. Adding CO2 prevented the CBF drop, but increased oxygen toxicity risk, a real double-edged sword.
And the human study using Doppler confirmed it's the high oxygen, not just the pressure.
That's what it indicated. Comparing HBO with just high-pressure air, the reduced blood flow velocity was linked specifically to the hyperoxemia, the high oxygen in the blood.
And this linked to reduced nitric oxide production early on.
Yes, another piece of the puzzle. It seems inhibiting NO synthesis contributes to that initial hyperoxic vasoconstriction. A study finding increased levels of an NO inhibitor supports this.
Okay, let's move to the blood-brain barrier, the BBB. Early studies hinted HBO might make it leaky, but that's not the current view.
Correct. Those early findings in healthy animals weren't really substantiated. Now, the thinking is more that in conditions where the BBB is already damaged, like in stroke, HBO might actually help decrease permeability and reduce leakage.
And that animal study giving HBO during a stroke, reducing BBB damage and swelling.
Yes, Veltkamp's study showed that intra-ischemic HBO reduced both early and delayed BBB damage and edema in rats and mice. That's potentially very significant for stroke treatment.
What about oxygen in the cerebrospinal fluid, the CSF?
Usually, CSF oxygen mirrors arterial oxygen, but in severe brain injury, blockages might prevent CSF oxygen from rising even if you give the patient lots of oxygen. This discrepancy can indicate injury severity and localized hypoxia.
Okay, so pulling these threads together, what's the core rationale for using HBO in neurological disorders? What are the main proposed benefits?
The chapter lists a few key mechanisms. Number one is relieving hypoxia, getting oxygen to starved tissue. That's the big one.
Right.
Then there's improving microcirculation, reducing cerebral edema via that vasoconstriction effect we discussed, potentially preserving tissue that's damaged but not dead yet, and improving cerebral metabolism, which we started with.
And it stresses that sometimes just breathing 100% oxygen isn't enough. You need the pressure from HBO.
Exactly. The pressure is key to dissolving much more oxygen into the plasma, allowing it to reach areas beyond blocked capillaries. Biochemical studies showing improved metabolism markers, like a better lactate-pyruvate ratio during HBO, support this shift towards aerobic energy production.
The mention of multiple sclerosis and this theory about fat microemboli and BBB issues was interesting.
Yes, Jain's concept. If vascular issues like microemboli, BBB dysfunction, and perivenous edema play a role in MS, then HBO, by potentially addressing these, could theoretically be beneficial. It's a specific hypothesis.
And this idea of breaking the vicious cycle in brain injury. Damage leads to swelling. Swelling worsens hypoxia. Hypoxia causes more damage.
Precisely. HBO aims to interrupt that cycle by boosting oxygen supply and potentially reducing the edema component. The chapter also nicely breaks down the types of edema: vasogenic, cytotoxic, interstitial, and their causes.
We know widespread edema is dangerous because of intracranial pressure, but it also mentions localized edema is getting more attention.
Right. With better neuroimaging, we're increasingly recognizing that even localized swelling around an injury site can significantly contribute to neurological problems beyond just the global pressure effects.
What did the animal studies on HBO and edema generally show?
Well, Table 18.2 summarizes a lot of them. Across various models, trauma, ischemia, etc., they generally suggest HBO can reduce edema, improve oxygen levels, and sometimes reduce mortality. But, things like the pressure used and the timing of treatment really mattered. Some newer studies even looked at preconditioning with HBO or early oxygen therapy, showing benefits in reducing edema and BBB disruption after brain bleeds.
And the older human studies? Head injury, post-op patients.
Those clinical reports, like from Jain, Hayakawa, Miller, Sakoff, indicated neurological improvements and suggested edema reduction with HBO. Pierce and Jacobson's view back then was that HBO could decrease vasogenic edema and maybe act on cytotoxic edema too, suggesting it as an adjunct therapy, usually below 2 ATA.
Which aligns with more recent studies showing reduced ICP and better metabolism at 1.5 ATA in severe TBI.
Exactly. It builds a consistent picture. The Rogatsky study in rats also showed early HBO reduced the rate of ICP rise after injury.
So the conclusion is HBO fights edema by reducing blood flow while keeping oxygen levels up, counteracting hypoxia.
That's summary figure, yes. It reduces CBF, which helps with vasogenic edema, but maintains oxygenation. Its effect on ICP depends on whether the brain's vessels can still react, and it doesn't cause the rebound swelling you can see with some drugs. But again, higher pressures risk toxicity, so 1.5 ATA is common for these uses.
Okay, shifting slightly neuroprotection, protecting the brain itself. HBO is seen as potentially doing this.
Yes. The chapter explicitly frames HBO as a neuroprotective agent. The subsequent studies discussed really explore how it might do that.
Like the one with neurons in a dish. Preconditioning with HBO helped them resist damage.
Right. Zheng's study suggested direct benefits against oxygen glucose deprivation, possibly involving PPAR gamma activation and boosting antioxidant systems within the neurons themselves. It implies HBO can make cells more resilient.
And in spinal cord injury, it might work via the nitric oxide pathway.
Ho Hong's study in rats suggested that, yes, modulating the INOS-NO pathway seemed to be part of HBO's neuroprotective effect in that model.
Then the TBI study in mice pointing to IL-10, an anti-inflammatory molecule.
That's Chen's work. It suggests HBO might exert some of its protection by promoting an anti-inflammatory environment, possibly mediated by IL-10. Inflammation is a big secondary injury factor.
And the stroke preconditioning study in rats. Increased SIRT1, reduced damage, better function, linked to antioxidants.
Sue's study, yes. It showed HBO preconditioning boosted SIRT1 expression, which is linked to cellular protection, and improved outcomes involving the NRF2 antioxidant pathway. It really highlights multiple potential molecular mechanisms.
So lots of potential mechanisms, but when it comes to actual approved uses, the list is shorter.
That's the reality check. Table 18.4 lists conditions where HBO has been reported or studied, based on the literature. But as the chapter notes, there's a lack of large controlled clinical trials for many of these. The UHMS in the US, which sets guidelines, only really approves it for cerebral air embolism among these neurological conditions in terms of typical insurance coverage.
So the science is intriguing, but clinical validation and acceptance lag behind for many conditions.
Exactly. The chapter then directs readers to later chapters for more detail on specific areas like stroke, MS, cerebral palsy, etc.
Now, how do you actually assess if HBO is working for a patient? It sounds like standard exams might not capture everything, especially if effects are temporary.
That's a key point. Because some benefits might only occur during the treatment, ideally you'd perform neurological checks inside the hyperbaric chamber.
That sounds challenging.
It can be, but the chapter suggests even brief exams, less than 5 minutes repeated during compression, at pressure, and during decompression, can be informative. Simple things like hand grip strength can be checked frequently.
And for patients who can't participate actively?
For comatose patients, you look at things like response to pain, muscle tone, pupil reactions, maybe fundoscopy, and track their Glasgow Coma Scale score. For someone with paraplegia, you'd check sensory levels, motor power, spasticity.
In hemiplegia?
Similar
Yeah.
things. Vision, motor tests like checking for arm drift, hand grip again, maybe using a tonometer to measure spasticity changes.
But a single session might not tell the whole story.
Definitely not. Improvement can be cumulative over multiple treatments. A lack of response in one session doesn't rule out eventual benefit.
Beyond the bedside exam, what about diagnostic tests to see HBO's effects? EEG was mentioned.
Yeah, electroencephalography. Historically, it was used more. Wassman's work showed decreased slow waves, increased alpha activity on the injured side during HBO, but recording inside older chambers was tricky.
Still used much.
Less emphasized now than imaging, I'd say. But there are new wireless Bluetooth EEG systems that make in-chamber monitoring feasible again, potentially even for detecting early oxygen toxicity signs.
Okay, what about imaging? Measuring blood flow seems crucial, especially for stroke.
Absolutely. Older methods used xenon inhalation, or PET. The chapter highlights XCT xenon-enhanced CT as advantageous because it integrates with standard CT.
Any study showing CBF changes with imaging?
Yes. Micarelli used fMRI techniques and found increased CBF distribution in certain cortical areas during HBO in healthy volunteers, suggesting potential benefits. And Chen used SPECT in CO poisoning cases with delayed problems, showing improved regional CBF that correlated with functional recovery after HBO.
Then the workhorses, CT and MRI. Quick recap.
Sure, CT uses X-rays. It's fast, widely available, great for spotting bleeds or calcification, good in emergencies. MRI uses magnets and radio waves, no radiation, much better soft tissue detail sensitive to early ischemia and edema, offers different sequences like diffusion-weighted imaging.
So MRI is generally better for detail, but CT is often the first step.
Pretty much. CT is crucial for distinguishing hemorrhagic from ischemic stroke quickly. MRI is superior for most other things, detecting smaller lesions, evaluating MS plaques, and showing ischemic changes earlier. Though MRI takes longer, can be tough for critical patients.
And studies using MRI to look at HBO.
Yeah, Neuro used a specific MRI sequence as a potential biomarker for tissue oxygen levels under HBO. Weir showed MRI evidence of improved BBP integrity and reduced edema in rabbit TBI models after HBO. And Tal found MRI evidence of increased CBF and brain volume correlating with cognitive gains in chronic TBI patients post-HBO, possibly due to angiogenesis.
What about PT scans? Positron emission tomography.
Powerful for measuring metabolism and blood flow using radioactive tracers. Can detect functional changes very early. But it's expensive, needs a cyclotron nearby, and resolution isn't as sharp as MRI. More of a research tool here.
Used in HBO studies, though.
Yes, studies using oxygen-15, PET, and CO poisoning and ischemia models have suggested protective effects of HBO. But again, limited clinical availability.
And finally, SPECT, single photon emission computed tomography. Sounds like a middle ground.
Kind of. It also uses radioactive tracers, but ones that are generally cheaper and longer lasting than PET tracers, making SPECT more accessible. It can assess cerebral blood flow using tracers like HMPAO.
How is SPECT useful for HBO evaluation?
It's particularly relevant for stroke. You can do scans before and after HBO sessions to identify areas of hypoperfusion, low blood flow that might be recoverable, sometimes called idling neurons. Neubauer and others showed HBO could reactivate these hypometabolic areas seen on SPECT.
Any other examples?
Golden's study showed SPECT evidence of improved CBF in patients with chronic neurological issues after HBO. And Azel used it in cerebral palsy, finding areas of decreased perfusion, with some showing improvement after HBO, which feeds into the ongoing debate about its efficacy in CP.
Wow! Okay, that was definitely a deep dive. We've covered a lot, from basic brain metabolism and blood flow right through to advanced imaging techniques.
We have. I think the key takeaway is that HBO seems to have these multifaceted effects, boosting oxygen, altering blood flow, reducing edema, potentially protecting neurons through various pathways. There's a solid scientific rationale building up.
A rationale, yes, but as you said, the large-scale clinical proof for many conditions is still developing.
That's the crucial balance. The mechanisms seem plausible, the preclinical data is often encouraging, and some clinical results are promising. But we absolutely need more rigorous, large trials to confirm where HBO truly fits in neurological treatment.
So here's a final thought for you to ponder. Given this complex picture, the known science, the potential benefits, the need for more proof, where do you see hyperbaric oxygen realistically fitting into neurological care in the future? Is it destined for niche applications, or could it become a more mainstream tool for certain acute injuries or rehabilitation? It really makes you weigh the science we have against the clinical validation we still need.
A question worth considering.
Thanks for joining us for this deep dive.